As the implementation of the Affordable Care Act, or Obamacare, progresses, the Department of Health and Human Services is taking away the religious freedom that all Americans are guaranteed by the First Amendment by requiring that all employers, regardless of religious conscience, provide all forms of contraception to their employees and even to minors without the knowledge of their parents. In response to this assault on the Constitution, Catholic leaders are stepping up and are searching for what can be done within the bounds of the law to deliver quality health care that follows the ethical and religious directives for Catholic health care services. The Make Straight the Pathway Conference was held in Houston, Texas in March of 2013 on the campus of the University of St. Thomas to shed light on the critical problem of providing quality health care and protecting everyone's religious freedoms. Tim Von Dohlen, co-founder and president of the John Paul II Life Center, presented a detailed explanation of how the Vitae Clinic, an OB/GYN medical practice in Austin, Texas, was formed and how it can serve as a model for others seeking to operate a medical clinic consistent with the ethical and religious directives for Catholic health care services. As Mr. Von Dohlen points out, perhaps the greatest challenge for an ethical clinic is financial viability, with the reimbursement rates paid for OB services without prescribing contraceptives or doing sterilizations. Utilizing many of the steps described by Mr. Von Dohlen, Dr. William Chavey of the University of Michigan Medical School details the steps for an ethical, multidisciplinary medical practice with financial viability. Then David Wilson, of Wilson Partners, an insurance specialist, explains how medical clinics might work within the healthcare system as it is developing in the United States today. Finally, some next steps are offered to allow plans to move forward to assist all persons interested in forming Christ-centered medical clinics throughout the United States.
I really want to divide my talk into two sections, and I want to talk a little bit philosophically with you for just a few minutes and talk about why we're even having this discussion of forming Catholic medical centers and clinics. Well, number one is because over the last 60 years, Catholics, particularly in the United States, have stopped sharing the truth and wanted more to be accepted, popular, and unalienated in the modern secular society. Second, because the church has spent billions of dollars on settling sex abuse claims and very little on programs to educate the laity on our changing time and the unchanging truths about Jesus Christ. Third, because as Martin Luther used the newly developed printing press of Johann Gutenberg in the 16th century to spread falsehoods about the Catholic Church, 600 years later, we see the church failing to use modern communication as a valuable tool to teach and educate on the truth. Fourth, because the public acceptance of contraceptives, sterilization, and abortions has brought about the weakening of the family and its exchange for personal instant gratification. And fifth, because the medical science of naprotechnology, which cures a woman's maladies, preventing conception, has not been understood by the church or the medical community, and naprotechnology medical treatment is either not reimbursed or at such a lower rate that it for a medically effective treatment, we can't understand why it isn't utilized more. So now let's look at two illustrations of what's going on with the United States government. One, I want to talk about the Global Health Initiative. $63 billion spent in foreign countries provided from this United States government after they did away with the Mexico City Accord, which prevented the funding of abortion in foreign countries. It was said by our former Secretary of State, Hillary Clinton, we're going to make up for lost time with the Global Health Initiative and this $63 billion, and we're going to provide this to countries all over the world so that we can control their population. Well, if we look now at the HHS mandate, you see that the HHS requires health plans to cover preventative services for women, including services that many citizens find objectionable for moral and religious reasons. And these objectionable services include sterilization, FDA-approved birth control, such as the IUD, Depo-Provera, morning after pills, and the abortion-inducing drug Ella, and education and counseling to promote these to all women of reproductive capacity, including minor girls. First thing we needed to do was to establish our mission, vision, and goals. Selecting your board members becomes extremely important. And any consultant or employee, in addition to your board members, you've got to know what your vision is. You've got to know what your mission is, and got to know what your goals are. And each person has to have a clear understanding of that. You've got to find the correct physician. And when I say that, it's not just the individual, but your consideration is, are you going to have an OB-GYN practice? Are you going to have a family practice? Do you want it to be just for OB, but you're going to use a family practice physician with a specialty in obstetrics? Because they get compensated at different rates, and it makes a huge difference in your financial performance. And to go out and find that physician, you need some help. And that's where One More Soul, and where's Steve? Steve's over here. If you haven't met Steve Koob, you need to meet him, because Steve has onemoresoul.org, and he can give you leads for where to find Catholic physicians. And then you've got to get your hospital to embrace your mission. And then, even though you're not a part of the diocese, what is your relationship with the bishop of the diocese? And we have an extremely close working relationship. And we are listed within the Catholic directory. Even though we're not a Catholic organization, the bishop knows and recognizes that we do everything to follow the teachings of the Catholic Church. And I will tell you, just as an aside, that made a huge difference recently when our insurance plan wanted to cause us to have all our employees covered by a contraceptive treatment and care, have the availability of that. We raised the question, and in Texas, we actually have, under the insurance code, a mandate that is as strong as the HHS mandate that already exists in Texas, but there is a religious exception. And we were able, by showing that we were under within the directory of the diocese, that we could fall within that religious exemption. So that becomes very helpful in having that relationship with your diocese. A very important question is, when can you start raising money? Because it's really a chicken and egg situation. If you start raising money too soon, you don't have anything to show people. If you haven't done things in order to create that provision with the people where they can see that you've done things, then it's hard to raise money. So getting to that point where you can actually raise money is really important. So how are we organized? How are we structured? It's the John Paul II Life Center and the Vitae Clinic. Each one of these is a separate legal entity, and each is their own 501c3. So what were the actual steps in formation? First, you have to create that legal structure to form the tax-exempt legal entity able to hire the physician. That's where Jack Selman was so helpful to us. Then you have to identify the physician, preferably an OB-GYN, could be a family practice specialist, but has those questions that I raised with you earlier. And then we wanted to create our sonogram center. Well, how do you go about that? Well, there are a lot of sonogram machines out there, but let me tell you, the Knights of Columbus program and their initiative to help funding up to 50% is wonderful. So we got a $150,000 system for just under $50,000 through negotiation and the Knights of Columbus help. Then it's essential to engage a practice management group. It's one thing to say, I've got a doctor. The doctors do not understand business. And it's not intended as a slam at doctors. Doctors want to do what doctors do best, and that's to help people. And so you got to have a good practice management group. And we were fortunate. We actually engaged the Texas Medical Association practice management group. Do they support pro-life? No. Do they make it clear they don't? Sometimes yes. Were they willing to help us? Absolutely. So you got to go where the help is, and as long as they let you do your mission, and they'll work with you. There's no reason not to use them. So you just got to be careful of what you're doing. Obtain your physician licensing. Now, there's a very important element here, and this has to do with Stark laws, and it has to do with getting your physicians licensed. If you have a relationship in Houston, Texas, and you want to open a clinic here, if you're in San Antonio and you want to open a clinic there and you found a physician who's already there, they can't do a recruitment agreement with you because that violates the Stark law. But if you bring in a physician from out of town, they can do a recruitment agreement with you. And that would have a huge impact on your financial position during your first year of operation. Then, if you bring the physician in from out of town, that individual probably was licensed in another state. They've got to come in and they may be able to reciprocate to your state, but they still are going to have to sit for an exam. And so getting that physician licensing is critical. Also, until you get the licensing and actually get open, you can't start your credentialing. So then location is important. You got to be close to your hospital that you're working with. You got to develop a marketing plan so you know what you're going to do. And then that takes us to the actual steps for the center. And now I want to make that distinction between the center and the clinic. What we did was to form a state nonprofit corporation and then applied for a 501c3 designation. We then knew that because of the corporate practice of medicine position, I can't go out and we can't go together and hire a physician individually. But we can create a Texas not-for-profit healthcare corporation that then doesn't violate the corporate practice of medicine provision, and that entity can go hire a physician. And that the board of that entity has to be a 3-person minimum board, all of physicians, all of who practice in Texas. And those physicians then run the clinic. The critical thing is to think about, we've got a distinct center that is a 501c3 and a distinct clinic. Now, in our instance, what we did was go ahead and get it as 501c3 designation as well. You may choose to leave it for profit. And then the operation of the physician, and if you have a multi-physician practice and it is profitable, the profits go in there and you share those profits based upon your division amongst the physicians. What we've done is have that to where people can contribute either to the clinic or to the center and they get a tax deduction. We have criteria for board membership. It's very important that everybody knows what's expected of them. You'll see down at the bottom there that each director couple, and we try to do everything that we do as a couple. And the couple has an annual financial commitment of a minimum of $10,000, either to give or raise that amount. And then we have certain other things, and we have a statement of faith that every board member signs, and employees sign, and volunteers sign. And we distinguish between volunteers and employees so that they are not necessarily embracing the Catholic faith as all Catholics would do that sign the statement of faith, but they are accepting to the beliefs of their co-workers and for themselves, that they accept what we're doing and that they will do everything to support them. Then just recently, we've added a nurse practitioner to our clinic. And that is a challenging thing for us right now because you've got to ramp up, you've got a tremendous additional cost, $7,000 to $8,000 a month additional cost, and getting that built into your pro forma is important. So what are our current challenges? We've got to get the correct patient mix. The idea is not to make a huge profit, but we got to at least break even. You've got coding limitations, and we're working on this, and we'd like to ask y'all's help for those physicians of you that are here in Texas to help us identify what are the limitations when you want to practice NAPRO technology, what prevents you from being reimbursed adequately or even reimbursed at all for those NAPRO services, and we can go to Medicaid and possibly get that changed. Doing claims collection is always a continuing issue. The Accountable Care Organization is a continuing challenge for us and how we adapt with that. The HHS contraceptive mandate, the need for a Catholic health plan, which we're talking about today, We've got growing pains, as I said, and then we've got to deal with Obamacare. So very quickly, for those of you, I think most of you know, and I'm not going to try to even venture into Obamacare in any detail, but I think you've got to realize the magnitude and the extent to which this law is changing the entire delivery of health care as we've known it. So the first thing is reimbursement change. You're familiar now with your fee-for-service delivery of medical care. This will change that from a transaction-based delivery of care to an episodic delivery of care. So if you have a knee replacement, let's just take it as an example, and you go in from the time you start that until you're fully recovered, not your exit from the hospital, till you're fully recovered. That's the episode, and it's going to be determined how much that episode is worth, and then you're going to have to divide that amongst all the participants. So quite complicated. More people covered, but less reimbursement per person. Do not expect increase in prices for 10 years. The margin growth that they want providers to see would be through savings through the Accountable Care Organization. Medicare population is being used to make the change. Patient population needs are increasing dramatically. Physician integration is well on its way. The government clearing the way for the Accountable Care Act itself. Post-acute care has a significant role to play. If you can imagine this, the target is 40% reduction in cost. That's the government's desire. And their first goal is no readmissions. So they have a major program going on now of not readmitting to hospitals within the 30 day of your discharge. And the integrated and coordinated care starts with the medical home. And the power change from the central CMS Medicare to your local market or ACO. Now, I'm not going to try to go through these. I just want to show these to you. If you want copies of them, I'll be glad to share them. But there is a roadmap to the accountable physician enterprise. And I've also got you a roadmap here for timing of the implementation of Obamacare. And that'll be up here if you'd like to. And then you'll see how capitation and shared savings models come into play, whether it's in, if you're talking about the capitation, shared billing, or if you're talking about episodic bundling, if you're talking about hospital physician bundling, or just pay for performance, as opposed to fee for service. And then you'll see here there are models for every episodic cost and site of care. So the two examples here are pneumonia and a joint replacement, and you'll see how that's broken down amongst all the participants. So, what are the solutions? First, consider becoming part of a Catholic ACO and health plan. So, do we have that health plan? That's what we're talking about the need for, and I hope I show you why this is so important on a local, regional, and national basis for us to be able to have that Catholic health plan. We can hope that the court strikes down the contraceptive mandate and preserves our religious liberty. Catholic men and women have got to stand tall for truth, to lead the Americans, to lead all of us to protect constitutional rights, including the free exercise of religion. We have to develop a nationwide network of pro-life medical centers following Catholic ethical and religious directives. Now, Pope Benedict has said that the American laity must have the courage to counter a reductive secularism which would delegitimize the church's participation in public debate. And John Paul II said, America, your very future as a nation depends on your willingness to protect the right to life of the most defenseless in your society. Well, the John Paul II Life Center and Vitae Clinic are committed to the care of human life. We are the Catholic answer to Planned Parenthood, and we've created a prototype for life. Our new logo, our new statement to represent the Vitae Clinic is embrace a better choice. So remember our challenges. Tell the story of the Catholic Church. Focus. Do simple things spectacularly well. Become people of possibility again. Have singleness of purpose. Be passionate. Be a light to the world. Francis of Assisi said, first do what is necessary, then do what is possible, and before you know it, you will be doing the impossible. Thank you very much.
I'm going to talk about something today that right now doesn't exist. If you Google Emmaus Healthcare, I don't think you'll find anything. You're certainly not going to find any details. But what I'm going to talk about is a concept, and I'll talk a little bit about our progress toward making this concept a reality. I think the Catholic philosophy of women is incredibly powerful and incredibly positive. But if you ask non-Catholics about the Catholic theology on women, it would be about all of those things that we do not do, not those things that we do. So I don't think that we can allow Catholic health care to be defined by the tyranny of the no. We also need care that's of the highest quality, it's efficient, cost-effective, and delivered in a transformative environment. The second is in part for evangelization. If we want to have people embrace a healthcare system, people who may not be Catholic, then we need them to come to that healthcare system because we're providing the best product in the market. We need them to come to us because the quality is that good. The second reason we need to embrace the second mission here is a business model. If we too narrowly define what Catholic healthcare is, then we cut off half the population or more. We need a business model that will allow us to survive and to sustain. What's the scope of care? I mentioned as part of the business model that we can't cut off part of our patient base, part of our customer base. So I think we need to provide more than just reproductive type care, but there are a lot of other services that would need to be ideally provided in terms of adolescent care, palliative care, addiction services, fertility, spiritual counseling, all of these types of things. What are the advantages of a proposed system? Obviously, it provides a product for those who have a particular interest in this model of care. And I think the selling point is that there is a business plan to be had. There is a market for people who want this type of care, and not all of them are Catholic. But I do think there is a market. It is an opportunity to provide a different model of care. I think it's also a valuable partnership for Catholic hospitals and health systems. An opportunity to develop a new model of care, as I already discussed, evangelism, education, advocacy, and a resource for formation of the Catholic physicians. In order to develop a clinic, we would need to network among other clinics that already exist. We've certainly heard about some, we'll hear about more. But I think if everyone is doing their own initiative in isolation, we lose out on the synergy that can occur. If we can network, there is so much greater efficiency and so much greater influence that can occur. And when people go into a community and they see that you are of this network of outpatient clinics, I think that will have a great amount of power. In order to become a Catholic Cleveland clinic, you have to have reputation. It's going to require marketing. It's going to require some scholarship. Part of it is redeveloping the brand. As I mentioned, I think we have allowed others to brand Catholic healthcare. We need to rebrand it for what it truly is. Some of that can be done through Catholic media. Some of that can be done with our quality of care. Some of that can be done through scholarship. One of the areas that is particular importance to me, and I think perhaps to a lot of you here, is this idea of what Catholic women's health care is. As I mentioned earlier on, I think we're defined by no contraception, by no sterilization, no abortion, no in vitro fertilization. But the Catholic philosophy of women is very positive. I think we need to develop a reputation around that whole initiative. I think we need to reach out even to people who disagree with us on those areas that we have in common, like domestic violence and human trafficking and issues such as that. We need to be seen as leaders in women's health care just as we've been seen as the leaders in the pro-life movement. We need to have that reputation. So to summarize the concept, this is our vision of a national network of outpatient Catholic healthcare centers that would be based on primary care, but that would also be providing a high-quality new model of care that would allow us to practice not just by the ethical and religious directives, but practice in a manner that would allow a holistic, Christ-centered, dignity-affirming approach to care. Where are we in this process? Currently, we're in the middle of developing in terms of a partnership with the Trinity Health System, who has a large hospital in Ann Arbor. They have a CEO who's very favorable to this concept, who sees it not only as part of his Catholic mission, but he also sees it as part of his business model. Once we get that agreement, we then plan to explore a number of the innovative ideas that have been developed across the country in terms of revamping primary care, and hope to put together an ultimate clinical model that will be very novel. With the clinical model in place, we'll develop a business plan to follow that and then get going. And that's all I have. I'm happy to entertain any questions. Thank you very much.
So what are the challenges that we have? The first is religious liberty. Why is religious liberty our first challenge? We've talked about it being our first right. If I'm not free to think and worship my God, I'm not free to do anything. We have to come together as a community to solve this issue and respond to it effectively. Without religious liberty, can I live passionately? For me, no, because Christ is everything for me. So now we go to the next question. Legal action, we've heard about that. The lawyers, we need them. We're in a litigious society. Legislation, we need that. But the daily transaction of life is commerce. When I get in a cab in New York, I know I'm going to pay the cab driver. But it's really important that we understand that the transaction of daily life is commerce. And so if we don't reflect what we're doing transactionally, including clinical care, we won't get there. People talk about cost in healthcare, and people talk about, does healthcare cost too much? There's no evidence that healthcare costs too much. There is evidence that quality is always the lowest cost. A caring physician, a physician that goes outside the boundaries of time-constraint management forced on them by the insurance transaction expense management cycle, has great value. But when a physician does that, they're not getting paid. And that's morally wrong. But it is true that quality health care is the lowest cost health care, and best quality health care is Christ-centered health care. Why? Because the human condition requires love. Caring requires time and passion. If you as a doctor cannot give your patient time and passion, then you can't deliver caring. This is not the bishop's problem. This is our problem. And when we cast the current state onto the bishops, we make a big mistake, in my own humble opinion, because it is up to us to take active and direct responsibility and to engage the culture. Why? Because we are the culture. We elect who we elect because that's what the culture elects. The House and the Senate are a reflection of the population, not the other way around. I think Congressman Fortenberry will share that view. If you really want to change the political environment, you do have to change the culture. They're one and the same. They are not separate things. Healthcare is the most intimate and passionate form of reward for productivity. It only tolerates moderate change, simplicity drives value, and there's no new money here. That's the axiom for healthcare management. Why have employees given up wages, given up pension, given up retirement, given up paid time off? The employer reduces their wages to afford additional cost of health care. Why? Because it's at the center of the human relationship. So you have an opportunity to truly have impact on the society because you're coming from the clinical side. I'm speaking specifically to the doctors. But we got to give you more time. And we got to give you more money. Everybody in primary care, we have to double to triple primary care to make the health system sustainable. How do you do that? We have a number of models that can get us there. But you're the leadership. You're also the light. But if you're just a candle on your block, as compared to being a light in the sky, we won't get there. And unless we do this in a way where we can generate income so we can sustain the effort. The second opportunity in the marketplace is self-insuring. all right? And you're not ever going to be too small to self-insure in the future. Why? Right? And this is really true. There's no employer in America that should go without an employer-based health care plan under ACA. I can show you the numbers. I can go through them with you. Examples, very simple. On the exchange, a single person, okay, or family person, excuse me, will actually, between the government, what the employee pays and the employer pays, will pay $22,000 for something that costs $15,000 in the marketplace. It makes no sense. So as long as we know that, self-insured plans are far better than insured plans under ACA. So here I've only got a little over 50 employees and I'm self-insuring. Why? Because I can simply say under self-insured plan that I'm not going to comply with ACA relative to that insured plan. I've got control of that plan. And the contributions my employees make to that plan, right? They don't have a moral consequence. They're participating in purchasing a plan that does not pay for contraception, sterilization, or in vitro fertilization. How do we do that? Well, there's mechanisms that you have to have in place, but one of those things is we empower the doctor to actually be engaged in health and well-being, actually creating true engagement tools. What do I prescribe a patient if they're healthy? What do you give them? You don't have a pill. You can't give them a pill. You can't go to refer them to the surgeon. You got to give them something. You have to engage them. You have to give them technology. You have to give them reports. You have to be able to get them day by day, week by week engaged in the management of their health. And guess what, Doc? You can get paid for that. Not through the insurance industry, through another mechanism. All right? So this is really important that we do this. But one of the elements is that we got to bring patient load. So we have the physician group there. We have this life clinic there. We have primary care and then NAPRO technology clinic. We got to deliver patients. So we got to go out to employers and we got to bring them into a mainstream environment that gives you patient load. All right? So I'm trying to simply say we have to have a unified, engaged solution, and we also need technology to do that. But we're going to execute one step at a time. So don't get frustrated with that. We're going to create a clinic in Colorado. We're going to create a clinic in Michigan, which we're working on right now, Mike O'Day and some others, and that are going to be here later tomorrow, tonight. But it's one step at a time, each group working individually. But we also have to optimize, right? Where I have already a health system with 12,000 employees and 600 primary care doctors in that community, and somebody who wants to open a NAPRO technology center, and I've already got the ear of the CEO of the hospital, do you think that could help? Yeah. But we got to work together to do that. One community at a time, in community.
Hi, I'm Jeff Gardner, and on behalf of the John Paul II Life Center and the Christus Medicus Foundation, thank you for watching this presentation. The need for more crisis pregnancy centers and Christ-centered medical practices throughout the United States is critical and ongoing, and we'd like to encourage you to get involved. Before you do, there are a couple of important takeaways that we'd like to leave you with. First and foremost, develop a strong and clear vision of what it is you want to create. Be sure that you understand the distinctions between a crisis pregnancy center, a family practice clinic, an OB/GYN clinic, a multidisciplinary medical practice, or a sonogram center. Familiarize yourself, too, with the not-for-profit laws as they pertain to healthcare in your state. John Paul II Life Center operates within the state of Texas. Your laws may vary. Also, before you begin either to explore a crisis pregnancy center or a Christ-centered medical practice, get the blessing of your bishop. Get a committed and unified board. If you can, get the cooperation of your local Catholic hospital. Organize and identify physicians who can be key in helping you getting your project off the ground. Develop a strategic plan, and within it include the right professionals, those that you'll need to advise you in all aspects of your endeavor. Familiarize yourself with the fundamentals of fundraising, communication, and education. Everyone involved does not need to know how to do everything, but everyone involved should know about everything that needs to be done. To open a Christ-centered medical practice, understand the financial operations of a clinic. When considering the financial arrangements needed to establish a clinic, it has been our experience that the first-year costs, including salaries, is a minimum of $500,000 and can be supported by a recruitment agreement for a physician with a cooperating hospital. Also, care should be taken to consult with an appropriate practice management company to assist you in setting up the medical clinic and to get the correct assistance with licensing, credentialing for hospital privileges, and third-party contracts, as well as billing and collections with the best electronic medical records and healthcare information technology available. Right now, a national platform is under development to include a service company that will help take advantage of economies of scale so medical clinics and pro-life centers across the United States can be created. For more information, please contact us at Kimberly@jpiilifecenter.org. That's Kimberly@jpiilifecenter.org.